Hey, Dr. G, let's get in a quick 10-minute session study. What's the next question?
With you, we'll be lucky if it lasts 5 minutes before you cry. Fine. What's the first thing you see when you make the horizontal vestibular incision for a BSSO? And don't say blood. I'm going to punch a hole in your knowledge base if you do.
Okay, I mean, first thing you might see is going to be that buccal. Shoot, God, what's it called? It's the buccal bone, bony protuberance on the mandible, the buccal wedge. I'm forgetting the name of it right now. I'm tired.
The external oblique ridge.
Yeah.
You absolute cunt. You're slicing through skin, mucosa, muscle, and bam. Right there, like a fucking speed bump, you better not nick with your saw, or your setback turns into a non-union real quick. You strip periosteum off it, retract, and move on. No finger in the socket, no hemostat in the socket, or it turns into a blood spray. That's first year shit. Next, what's the only way to tell if you're too far back on a BSSO setback? Answer quick before I smack your sleepy ass.
If you're too far back on a BSSO setback, I mean, too far back where? On the anterior cut or the posterior cut, the medial cut? Which cut are you talking about?
Posterior cut, you dumb fuck, where you start your sagittal split. If you go too far back, your saw kisses the internal oblique ridge. You fracture the proximal segment like a cheap plastic ruler, and the whole mandible slides sideways instead of backwards. You feel it. There's no bone between the saw and the mandibular canal. You're 1 millimeter from paralysis. You stop at the lingua. You don't tunnel like a mole. Now, what's the only instrument that saves your ass when the saw gets stuck? Say it.
We usually like to use a Selden to protect the vessels and the tissue when we're doing the BSSO cuts.
Selden? You mean Selden? You use
the Selden retractor.
The Selden retractor. Yes, you brain dead, half asleep idiot, that's what you meant. You hook it under the ramus, protect the lingual nerve and vessels so you don't bleed out like a stuck pig when the split cracks. But the instrument that saves you when the saw's stuck is an osteotome. With a mallet, you give 2 little taps and pop. The bone separates like a divorce. No, you're not hitting it like Thor. Next, what's the only thing you do before you actually place the Leafort eye osteotomy? Cuts if the patient's got a short palate. And don't say nothing. You'll kill their speech. You don't Leafort a short palate patient unless you like lawsuits with voice boxes. Next, name the single best way to prevent mandibular relapse in a BSSO setback. Don't say plates.
To prevent setback, number one thing would be to obviously evaluate condylar positioning. Before the patient goes home, we like to get a Panorex, evaluate the condylar position. Next thing, probably the best thing would be guiding elastics. I would say guiding elastics. What do you think?
That's what you give a goddamn toddler with braces. To prevent relapse in BSSO setback, you do one thing. Cut the genioglossus and geniohyoid, like snipping puppet strings, so the suprahyoid sling doesn't yank your pretty setback forward. Then you rigid fix with 3 bicortical screws each side and let the muscles heal at length. Elastics for 3 days post-op to close, then off. Anything longer and you're training the relapse, you dumbass. X-rays, useless. You see the condyle sitting pretty in the fossa with fluoroscopy before you close. Next, what's the first symptom of pterygoid venous plexus? Bleed during BSSO split. Don't say oops.
Pterygoid venous plexus bleed, gauze pressure packing with gauze, and maybe using hemostatic agents. Hopefully we're giving TXA in the IV. It's a young, healthy patient to do that with. What do you think? What was the answer?
The answer's massive hemorrhage, spurting dark blood from the medial aspect of the split, faster than you can swear. You don't think about TXA then. You throw your thumb on it, thumb pressure, and yell for suction. Hemorrhagic agents are for later. Gauze now. 5 minutes or your floor turns red. Next question. What's the most common cause of velopharyngeal insufficiency after maxillary advancement? Don't say the maxilla move.
I'm not sure. What's the answer?
You shortchange the soft palate. Stretch it too far when you advance the maxilla, like yanking a rubber band until it snaps. Boom, food rockets out the nose every swallow. Fix, VY closure with tensor tenepexy. Don't leave it flappy. Next, what's the only absolute contraindication to bimax surgery in a class 3 with OSA? Don't say they're ugly.
That's another great question. I don't know what the answer to that is. I mean, you could do a coronoidectomy.
Coronoidectomy, yes. You saw that bony son of a bitch off with an oscillating saw or chisel. Toss it in the bucket like yesterday's sandwich, because it blocks your setback like a goddamn bouncer. 3 millimeters of bone, but that's enough to fuck your occlusion. Do it early, before you split or you're drilling blind. Next, What's the single best predictor of relapse after BSSO setback? Don't say the patient cheated. Say it.
Oh, what is the single best predictor of BSSO after BSSO step?
Yeah.
All right.
Don't say.
Gotta go. Gotta head into work. So these quick sessions, sometimes like today, exhausted. I'm getting up at 5:30, going to bed at like 12:30 a.m. Maybe getting up a little earlier if like my body starts to wake up at around 5:11 when the alarms go off. But you got to make time. So the first 6 months out of residency, you think you're gonna have all the time in the world, and it's gonna be a definite growing period. You're gonna have to adapt to a lot of changes, a lot of new schedules, a lot of different things in your routine. My 5 to 10 minute commute through residency is turning into an hour to an hour and a half of just total time. But that's a whole workout that I'm struggling to fit in right now, in addition to starting to work full time, which is great, and I love it. I'm not complaining. I'm just giving you a heads up when you're studying for these in those first 6 months or in your second year out of residency, depending on if you have fast track at your program or not. There's something to expect. There's a lot of growing pains, a lot of changes, a lot of things to adapt to. I'm just trying to get the mortgage ready to go. I'm trying to find a hospital to get privileges at, and I've only been hitting speed bumps there. It's like they want like packets and packets on top of things that you need to send in and fill out. And I'm going to have to take off from work to get a doctor's appointment or something to get a doctor's physical to hand into the hospitals. At least on Long Island, you have to pay to hand in those applications. And they're going to make you cover a clinic once a week, maybe take call a couple weeks or months a year. And you're not going to get paid for that from my experiences of my applications to all these programs, these hospitals. In order to schedule the board's exam, they want to see that you have pending hospital privileges, and everyone I've talked to won't sign my pending hospital privileges form until I have completed getting hospital privileges. So experiencing a lot of pushback there. This is all on top of starting residency, starting working, studying for boards on top of that, and so it's just there's a lot of things going on right now. Overall, it's so much better. All on top of starting and on top of studying for the board's exam when I don't even have it booked yet because I'm having all this pushback. I'm not going to be working for free. We'll work for free for basically most of residency. So I don't think that's appropriate, especially when in other states they do pay you to take call. Connecticut's like $5,000 a month. Rhode Island or Massachusetts $7,000 a month. Palm Springs, California, I know someone there that's $15,000 to $20,000 a month that they pay you to take call and work in the hospital. But in Long Island, they're not paying you to do that. You have to like bill out to the insurance separately, and the insurance doesn't reimburse any of that. So it's free work and taking off from work. So it's less money coming into your pocket, and you have to you're basically paying to do the work, which just doesn't seem appropriate, after all the years of education and training. But you want to do it, you want to help, but it's becoming you're losing money to do it, which is one thing, but also now it's so challenging and like so many speed bumps to getting this process. So it's just giving you the information you need to anticipate what's going to happen after you graduate residency. So if you listen to this, all right, friends, I gotta go get ready. Have a great day.